Assalamu alaikum. Let's discuss about Hirsutism. Hirsutism means excessive hair growth in the most common causes of hirsutism in women is polycystic ovarian syndrome, idiopathic hirsutism. There may be non-classic 21 hydroxylase deficiency. There may be androgen-secreting ovarian tumor, ovarian hypertrichosis, and there may be Cushing syndrome. Okay, what happens in the PCOS in polycystic ovarian syndrome? Polycystic ovarian syndrome. For diagnosis of polycystic ovarian syndrome using the Rotterdam criteria, which requires two of the three criteria. According to Rotter, according to Rotterdam criteria, you need two out of three. One is an ovulation, second one is hyperandrogenism, either clinical or biochemical, like increased serum testosterone level, and there may be polycystic ovaries, hyperandrogenism, and there may be polycystic ovary. So polycystic ovarian syndrome, for diagnosis of the polycystic ovarian syndrome, we need two out of these three: an ovulation, hyperandrogenism, and polycystic ovaries. Okay, so it is associated with type 2 diabetes, dyslipidemia, and hypertension. It is associated with type 2 diabetes, dyslipidemia, and hypertension. How we can diagnose this polycystic ovarian syndrome? Specific to polycystic ovarian syndrome, there are some specific uh, investigation, like we remember it, like leptin, LH, estrogen, prolactin, testosterone will be increased. So leptin will be increased. So serum testosterone level will be increased. There may be serum 17 hydroxyprogesterone level. It is normal in patient with PCOS. But these serum 17 hydroxyprogesterone level is done for why? For rule out these non-classic 21 hydroxylase enzyme deficiency. Look, it has similar feature like PCOS. If you do the Rotterdam criteria, you may think that is it PCOS or is it non-classic 21 hydroxylase enzyme deficiency? So how can you differentiate? By doing this test. Serum 17 hydroxyprogesterone level, it is elevated in non-classic 21 hydroxylase deficiency, but it is normal in polycystic ovarian syndrome. And dihydroepiandrosterone sulfate, DHEA, DHEA, dihydroepiandrosterone, dihydroepiandrosterone level, if an adrenal tumor like rapid hyperandrogenism is suspected at DHEA a label is ordered. If rapid hyperandrogenism is suspected, then this label is ordered. However, it is not routinely ordered in most cases with suspected PCOS. So, in PCOS, first we do the criteria, then we do the tests. There may be comorbidities like already I've told you diabetes, dyslipidemia, hypertension. There may be other comorbidities also, obesity, obstructive sleep apnea. There may be NASH, non-alcoholic steatohepatitis, and there may be endometrial hyperplasia and cancer. And for as a treatment of PCOS, we need first line is weight loss, then oral contraceptives for menstrual regulation, and letrozole for ovulation induction. Letrozole for ovulation induction. So if we find a patient with hirsutism, excessive hair in abnormal location, so uh, we need to look at this. And for idiopathic hirsutism, in idiopathic hirsutism there is normal menstruation, normal serum androgen. There may be normal menstruation and normal serum androgen. Okay, if we think about the Cushing's, this one, in Cushing syndrome, there may be uh, it may be ACTH dependent, it may be ACTH independent. If it is ACTH dependent, that means Cushing disease, that means ACTH secreting pituitary adenoma or ectopic ACTH secretion. The distinguishing feature in between these two, how we can distinguish between ACTH dependent and ACTH independent. In ACTH dependent, ACTH will be high. In ACTH independent, ACTH will be low. In ACTH dependent, like in Cushing disease, there may be hyperpigmentation, there may be hyperandrogenism, there may be hyperpigmentation, hyperandrogenism, and there may be increased ACTH, hyperandrogenism like again hirsutism, oligomenorrhea, amenorrhea. And in the Cushing syndrome, there is obesity, truncal obesity, obesity in the face, neck, abdomen. There may be increased libido. There may be virilization. There may be irregular menses. There may be irregular menses. For diagnosing Cushing syndrome, for diagnosing Cushing syndrome, we can do 24-hour urinary cortisol low dose overnight dexamethasone suppression test and late night salivary cortisol test. These three things can be done initially. Okay, now androgen secreting ovarian tumor and ovarian hypertrichosis. It may be postmenopausal, it is rapidly progressive hirsutism with virilization. There may be rapidly progressive hirsutism with virilization. There may be high serum androgen level. So androgen secreting tumor, there may be high serum androgen level, mostly postmenopausal and rapidly progressive hirsutism with virilization. So this is all about the causes of hirsutism in women, and Cushing syndrome may be similar presentation to the PCOS, but PCOS does not cause muscle weakness nor easy bruisability. This differentiating point is a very high L to deal the question. Like Cushing syndrome has similar features like PCOS. PCOS has similar feature like non-classic 21 hydroxylase enzyme deficiency, but we can differentiate by the tests. If there is elevated serum 17 hydroxyprogesterone, it is non-classic 21. If it is polycystic ovarian syndrome, it is normal, um, normal serum 17 hydroxyprogesterone. And in Cushing syndrome is similar feature like polycystic ovarian syndrome, but we can differentiate by the by this by in Cushing syndrome there is muscle weakness and easy bruisability. So that is all about hirsutism in women. Hope you enjoyed.